Hi, I'm Vllanos, and this is my synthesis project. Discharge from the hospital represents a critical transition in the continuum of care for adult medical surgical inpatients. During this period, patients must absorb, recall, and act upon complex information regarding medications, symptom monitoring, and lifestyle modifications. However, research consistently shows that many patients leave the hospital without fully understanding their discharge instructions, placing them at a risk for post-discharge complications, medication errors, and unplanned hospital readmissions. The teach-back method is a structured communication strategy in which patients restate information in their own words to confirm understanding. This has emerged as an evidence-based approach to improving comprehension and adherence to discharge plans. Improving patient comprehension through teach-back supports public health goals by optimizing healthcare resource utilization and reducing preventative hospitalizations. Ensuring patients understand their discharge instructions promotes autonomy and informed decision-making, particularly for individuals with low health literacy or language barriers. Failure to ensure comprehension can lead to inequitable outcomes and potential harm, making effective communication a professional responsibility for healthcare providers. Regulatory bodies also emphasize safe care transitions and health literacy standards as part of quality metrics. Studies demonstrate that the teach-back method effectively improves comprehension, self-management, resulting in lower readmission rates, and improved continuity of care. By integrating teach-back into discharge practices, healthcare providers can improve communication, enhance patient safety, and reduce unnecessary healthcare costs. My PCOT is, in adult patients receiving discharge instructions, how does the use of teach-back method compared to standard verbal instructions affect patient comprehension, self-management, and readmission rates within 30 days post-discharge? The database searches included PubMed, Medline, and CINAHL. Keywords and search terms included teachback, discharge instructions, discharge education, 30-day readmission, and hospital readmission, patient comprehension. Filters were applied to include studies published in English involving adults aged 18 years and older, and focusing on inpatient settings. Inclusion criteria were studies involving adult inpatient discharged to home who received discharge instructions. They also included where teach-back was used as an educational intervention, and outcomes included patient comprehension, knowledge retention, and 30-day hospital readmission. Both primary research studies and systematic reviews or meta-analysis were included. Exclusion criteria included studies limited to pediatrics, obstetrics, psychiatric units, or outpatient-only settings, studies without comparison, or non-English language. The initial search yielded approximately 1,750 records. After removal of duplicates and screenings of titles and abstracts, 48 full-text articles were assessed for eligibility. Application of inclusion and exclusion criteria, along with the quality appraisal, reduced the pool. These included studies like 2 systematic reviews, meta-analysis, and 4 primary research studies evaluating teach-back interventions in adult inpatient populations. The body of the primary quantitative evidence indicates that interventions using the teach-back method at hospital discharge are generally effective in improving patient comprehension and reducing 30-day hospital readmission, particularly among older adults and those with complex care needs. Multiple systematic reviews and meta-analysis consistently demonstrate that teach-back improves patient recall of discharge instructions, medication adherence, and self-care behaviors. Structured interventions appear to enhance effectiveness. While no studies directly contradict these findings, controversies remain regarding the magnitude of effective in populations with severe cognitive deficits or advanced multimorbidity, suggesting that tailored approaches may be necessary to optimize outcome. The planned change settings would include areas such as medical surgical units, the emergency room, urgent care, or rehab facilities. For the change model, I selected the Plan, Do, Study, Act model because it aligns well with both organizations' quality improvement structures and my very own preference for data-driven and practical change processes. PDSA evaluation is conducted in iterative cycles for each change, which involves constructs that identify key issues, develop small, actionable changes, evaluate outcomes, and reflect on the next steps moving forward, which then highlights the lessons learned or lead to a new cycle of identifying additional issues to be addressed. I chose this model because it's flexible, familiar to most hospital systems, and highly effective for implementing and evaluating behavioral workflow changes like teach-back. It also ensures that the practice becomes sustainable by integrating training, documentation, and feedback mechanisms into routine operations. When evaluating the evidence-based practice change of integrating the teach-back method into discharge instructions for adult medical surgical inpatients, it's important to consider outcomes that capture both the clinical effectiveness of the change and the qualities of its implementation. The primary clinical outcomes I would focus on are patient comprehension of discharge instructions and 30-day hospital readmission rates. In addition, incorporating process outcomes such as nurse adherence to teach-back steps, confidence in using the method, and perceived barriers helps explain variations in results and supports continuous improvement during implementation. To measure these outcomes, I would use a structured approach. Patient comprehension could be assessed using a brief, validated comprehension tool or a standardized teach-back checklist, completed immediately after discharge teaching. 30-day readmission data would be obtained from electronic health records. Process outcomes could be collected through periodic nurse surveys and brief observation audits to evaluate fidelity to the intervention. Formative evaluation requires ongoing data collection, so the real-time adjustments can be made to support successful adoption. The level of evidence that will be used for this project proposal is primarily Level 1 evidence, derived from systematic reviews and meta-analysis that provide the strongest empirical support for evidence-based practice. These studies synthesize data from multiple randomized controlled trials, demonstrating the effectiveness of communication-focused discharge interventions. These studies are supported by Level 3 evidence from quantitative cohort studies, which identify common predictors of readmission such as post-operative complications, delirium, and polypharmacy. Common themes found throughout the literature emphasize that structured communication during discharge, including the use of teach-back method, significantly enhance patient comprehension, satisfaction, and adherence to care instructions, which lead to fewer readmissions. Engaging patients and caregivers actively in the discharge process is another consistent finding across these studies, as it improves understanding and self-management after hospitalization. So overall, the literature provides strong level 1 evidence supporting the implementation of teach-back and structured discharge communication as effective, patient-centered strategies to reduce hospital readmissions and enhance continuity of care. A comprehensive dissemination plan is essential to ensure that the findings from the evaluation of the teach-back evidence-based practice change reach appropriate audiences and support broader adoption. At the institutional level, results would be shared through presentations at Nursing Leadership Council meetings, medical surgical department meetings, and interprofessional department rounds. Locally, findings could be presented at community education forums and partnering nursing schools to promote alignment across affiliated organizations. Regionally, dissemination would include poster or podium presentations at State Nursing Association conferences, Hospital Association quality and safety forums. So to reach a national audience, presentations could be submitted to conferences such as the American Nursing Association Quality and Innovation Conference, the Academy of Medical Surgical Nurses Convention, and the Institute for Healthcare Improvement Forum. In conclusion, discharge from the hospital represents a critical transition in care for adult medical surgical inpatients, during which patients must understand and act upon complex instructions related to medications, follow-up, symptom monitoring, and lifestyle adjustments. Evidence consistently demonstrates that many patients leave the hospital without fully comprehending these instructions, placing them at risk for post-discharge complications, medication errors, and unplanned 30-day readmissions. The teach-back method, a structured communication strategy in which a patient restates information in their own words, has been shown across multiple systematic reviews, meta-analysis, and primary studies to significantly improve patient comprehension, adherence to discharge plans, and self-management behaviors. Overall, the teach-back method represents a patient-centered, evidence-based practice that improves safety, promotes autonomy, reduces 30-day readmissions, and supports equitable and ethical care transitions. Implementation should include structured protocols, staff education, and documentation of patient comprehension to ensure consistent and effective integration into discharge workflow. Thank you. If there are any questions, please feel free to submit those. Thank you.